What I'm going to give you is my perspective as someone who actually trained and practiced in Britain for a number of years and has been in the United States now for almost 30 years. So I have a kind of transatlantic approach to medicine and a transatlantic approach to prostate cancer. I'm also trained both as a medical oncologist and a radiation oncologist, so I don't necessarily see things entirely through the eyes of my specialty. Now, what I've been asked to talk about today is the role of radiation therapy in intermediate and high-risk prostate cancer. Now, I just have grouped those two together, and I'm going to call those clinically important prostate cancers, as opposed to the low-risk prostate cancers, which may well, in many cases, be unimportant. Not for the individual, but at least not in terms of a threat to life. And if you go back to when I first came to the United States in 1986, there were 80,000 cases of prostate cancer a year, and the vast majority of those were clinically important. They were intermediate and high-risk cases. Nowadays, because of PSA, we diagnose 3 times that number, but only a smaller proportion are actually intermediate and high risk, although it's still quite a large number, about 50,000 a year. So we really do have to give it thought, because these are the cases that go on to create problems, to need additional treatment, and potentially to be fatal. Now, you've heard already from Maha Hussein about evidence-based medicine. This is the modern mantra. This is the sort of spiritual core of modern medicine. We want to do things because they are helpful to patients, and we know it. It turns out that many studies have been done. Not much more than 50% of what we do in medicine is actually evidence-based. It's just hard to generate all the evidence for all the diseases in all the different scenarios. And then there's evidence and there's evidence. Not all the evidence is good. So only about a third of what we do in medicine generally is truly grounded in good evidence. A lot of it's grounded in experience and instinct, and not that there's anything wrong with those things, but it's hardly good science. So when we evaluate evidence in medicine, we have, you have the food triangle with all the things you can eat lots of down at the bottom and the things you shouldn't eat much of at the top. Well, the evidence pyramid is something like that. At the peak of evidence, the thing we should be doing most of, the highest quality evidence, is the RCT, the randomized controlled trial, where you take 1,000 guys, you randomly assign them either to treatment A or treatment B, and you compare the outcomes. That's the ultimate. There are other forms of evidence, and down at the bottom, the lowest form of evidence is opinion. In my last case, this seems to work. I've seen this once before. But even below that is advertising and very often the internet. The good news is for men with intermediate and high-risk prostate cancer that's apparently localized to the prostate, that our treatments are actually grounded in evidence. It's a remarkable thing. It doesn't happen throughout medicine. So, broadly speaking, when we, in our multidisciplinary clinics, see men with clinically significant prostate cancers, they can take one of 2 paths. They can either have radiation, but remember, because they have high-risk prostate cancer, radiation alone ain't going to get the job done, and it's usually accompanied by some androgen deprivation therapy, or hormone therapy. Or they could take another path. They could have surgery. They could have a prostatectomy. But that, because this is high-risk disease, will probably have to be accompanied by some radiation or some hormone therapy sooner or later. And these are both perfectly legitimate paths for any patient to take. And the goals of both paths are the same. We're headed for the same destination. Cure, which means freedom from any further therapies, and of course a good quality of life. So, why might a guy take the surgical road? What's the appeal there? Well, he does get the chance to avoid immediate hormone therapy, and you do get some more important pathologic information. What's the downside? Well, surgery, as everyone in this room knows, has its baggage. There are the general risks of any operation, and then there are the specific risks of this operation, particularly incontinence. And you may go through surgery and may still need radiation and hormone therapy. In fact, probably will. So the alternative might be to take the radiation road. What's the appeal of radiation? Well, the first appeal of radiation, no surgery. Because it comes with hormone therapy, there is an early attack on any metastases that may be out there hiding. But probably the most important reason to consider the radiation road is there's lots of high-quality evidence built up over 3 decades behind it. So what's the downside? Well, again, for intermediate and high-risk disease, you would need some hormone therapy to go with it, either for a short period of time or for longer, and you don't learn any more about your cancer. But you don't necessarily need to know. Time will tell you. So let's have a look at the evidence that backs up the use of radiation for men with clinically significant cancers. There are certain questions that we ask, and certain questions we have answered with randomized trials, the best evidence. Number one, most importantly, does radiation cure men and extend lives? And we have the Swedes to thank here. Sweden is a wonderful nation. It was put on this earth to do randomized trials. Well, that's how it seems from a physician's perspective. All the trials that we cannot do in the United States can be done in Sweden. You want to do a trial, no treatment versus surgery? You do it in Sweden. You want to do a trial, hormone therapy versus radiation therapy? You do it in Sweden. So we've got a lot to thank the Swedes for. We've also got a lot to thank the British for and the Canadians. Those are 2 other nations that are very deeply involved in very difficult randomized trials. So this was a trial that was published in The Lancet about 5 years ago. It looked at men with high-risk prostate cancer. All of them got hormone therapy, half of them got radiation. And the guys who got hormone therapy alone, 50% of them were progressing within 3 years. Of those who got hormone therapy with radiation, that number was far, far fewer. And this translated into a 50% reduction in death at 10 years. Big deal. That's a big, big deal. So we could show there that radiation was important. Now, ask the question the other way around. Does hormone therapy make radiation more effective? Again, we have a number of randomized trials, all showing the same thing. If you combine hormone therapy with radiation for intermediate and high-risk prostate cancer, you save lives. There are fewer metastases, more men alive at 10 and 15 years. Now, if you've got intermediate risk prostate cancer, you probably only need 4 to 6 months of hormone therapy. If you've got high-risk prostate cancer, it's 2 to 3 years. How do we know this? Randomized trials. Now, what about this? How does radiation compare to surgery? Well, don't let anyone tell you they know, because they don't. This is the trial we do not have. And as far as we know, for intermediate and high-risk disease, they are comparable. We will know, however, because the trial of the century has taken place in Britain. This was a trial that was started in 2001, 2002, if I remember rightly. I'm on the steering committee of this trial. We've randomized 250,000 men. 250,000 men. Half have PSA screening, half don't. Because remember, that's controversial. Of those who have PSA screening, when their cancers are discovered, they are randomized to surgery or external beam radiation with a little bit of hormone therapy, or, if they have low-risk disease, active surveillance. This was the trial that It just was impossible in this country, where everyone, physician and patient, has their own idea of how they want it to be treated. The remarkable thing is that not only was this trial completed, it was completed ahead of schedule. It's a remarkable, remarkable effort. The British government decided the questions were so important. They've invested $25 million in this trial, and the results will be reported late in 2015, and I can assure you it will be in the New England Journal. A lot of people are anxiously awaiting the result of this trial. I think it's going to define the practice for localized prostate cancer for the decade to come. When it reports next year, it will have 10 years median follow-up, which is a good length of time. Now, what else have we learned from randomized trials? When men are treated with radiation, is it better to give higher doses? And the answer, there have been 5 randomized trials, yes. So most of you, if you're treated with radiation, are going to receive high-dose radiation because you're less likely to recur. But we got worried. Higher doses of radiation, won't that increase the toxicity? Well, it turns out that with a number of things which I'll talk about in a minute, that's not the case. And the randomized trials, this is just one of them, and I'm not going to dwell on the data. Simply know that 70 gray is a standard dose of radiation, 79 gray is a high dose of radiation, and the numbers, and these are symptom scores for patients, but we won't go into the detail, the numbers are the same. It seems like you can give high doses of radiation safely. Now, one of the big knocks on radiation therapy is it goes on forever. Guys say, well, 8 to 9 weeks, I can't stand it. Do I have to, Boston traffic or LA traffic? Couldn't this be done more quickly? The answer is, in the past, no, because we had to give radiation slowly and gently because of our fear about normal tissues. Now, with better targeting, the answer may well be yes. And there are 3 randomized trials going on at the moment. So the current radiation treatment is 5 days a week for 8 to 9 weeks. I can tell you that by next year, it may well be down to just 4 weeks. In breast cancer, it's down to 3 weeks. And in the years to come, because we have randomized trials testing this, we may be getting all the radiation done in just 1 week, which makes it a very patient-friendly, convenient, and competitive option. 1 week, giving all your radiation in 5 big treatments rather than spread out in 40 small treatments is what we call hypofractionation. And that 1 week treatment is extreme hypofractionation. And we have trials that are going to answer the question of just how low we can go. Now, you're going to hear a great deal about high technology in medicine, high technology in radiation therapy. Turns out that low technology is incredibly important. And some of the biggest advances in radiation oncology over the last 10 years have been low-tech, low-cost, high-impact. The first of these was the discovery. We should have known this, but we had to see it for ourselves, that the prostate moves from day to day. It depends upon whether the rectum is full or empty, or the bladder is full or empty. And every day it's in a slightly different position. And as radiation oncologists, we're trying to be sharpshooters. If we only treat where it is on day 1, then half the time we're going to miss the target. So we have to follow that prostate around every single day with our treatment. So this is just 3 consecutive days. This is CT scans taken of 1 man on 3 days. And you can see the prostate in the middle is dancing up and down. The rectum behind is opening and closing like a politician's mouth. The hips up and down, like this, wedding dance. And all of that can affect your radiation. So now we put little markers, little gold seeds costing no more than $20 into the prostate. We can see the prostate every day and adjust our beam. We put balloons in the rectum to hold the prostate still. And we can do mini CT scans prior to each treatment. This whole collection of maneuvers is known as image-guided therapy. And it's what we all now do, thank goodness. Because back in the year 2000, almost none of us were doing it. by 2009, it was up to 90%. So this is a simple practice that has become really pervasive in the practice of radiation oncology. Now, we're in LA. In Hollywood, I know people with British accents always play the villain. So that's kind of where I'm going. Can high technology advances improve the outcome? Well, the answer is, of course, yes, but not always. And there's what we call the technological ladder. Conventional external radiation is really by conventional, it's what we used to do back in the 1990s. It was poorly targeted radiation. It didn't take advantage of, it took full advantage of what we had available then, but we didn't have that much available in terms of imaging. Then we moved to what was called 3D therapy by the mid-1990s, late 1990s. And a randomized trial was done, again in Britain, comparing 3D radiation with the old-fashioned radiation. There was a clear advantage to patients, less side effects. That was clear, it was proven. Now, over the last 10 to 15 years, we've had a massive proliferation, nuclear proliferation of radiation technologies. And there are so many of them. They're all aiming to do the same thing, deliver radiation accurately. They do it this way, they do it that way. But there are so many of them, it's very difficult to distinguish between them. Yet each of them have their passionate advocates. And it's sort of incumbent upon us as a specialty to try and sort between them for you. Are they all the same? Fine. Is one better than another? We better know it. Are any worse? Better know that. That's what we've been not so good at. And it's particularly important because some of these new technologies are highly expensive. I'm just going to move on to the highest of all these high technologies, and it's very relevant to LA. There is something called proton beam. Can you put your hands up if you've at least heard of proton beam? Everyone. Okay. Put your hands up if you've been treated with proton beam. Not so many people, but some. Proton beam is an eye-catching, eye-popping, space-age technology. With regular radiation, this is what I call the searchlight principle. We shine radiation beams into the patient, and where they cross is where most of the radiation is deposited, that white diamond on the left. But of course, everything on the way in is irradiated, and everything on the way out is irradiated. Proton beam is a beam you can stop still in tissue. So as you can see from the panel on the right, there's no tail on the searchlight. That's a very cute idea. The problem is, it will cost you something like $150 to $200 million if you and your institution want to put in a proton facility. And it is literally the mother of all medical devices. There is nothing in medicine, other than building a new hospital, that costs this much. There's no MRI scanner that costs you more than $3 million. Even putting in a whole cardiac catheter suite will only cost you a few million. This is $150, $200 million. So it caught the attention of journalists and politicians and health policy folk. And it's very important as a result. It has become the exemplar of expensive medicine. And thus, my specialty, radiation oncology, we used to be a tiny little specialty that just flew below the radar screen. No one knew who we were. Everyone left us alone. But now, because of protons, we're very much in the public eye. And we're very much discussed on Capitol Hill. Now, one of the problems, as Maha Hussein was explaining, as regards drugs, there are a lot of vested interests. If you take a stand against a drug at the FDA level, you may get death threats. We have the same problems with our technologies. There are huge vested interests. Some of them are patient advocacy, some of them are investors, some of them are company officials. And these, when there is an absence of evidence, these influences can become very powerful. And the evidence pyramid can be stood on its head, with the randomized controlled trial down at the bottom, and advertising, advocacy, and the internet becoming the most important drivers of a technology. Now, I happen to love proton beam therapy. We have it at Mass General. I think it is the best treatment for pediatric cancers. I think it is the best treatment for cancers of the eye, cancers of the spine. But maybe not so much else. At Mass General, 80% of the patients we treat are pediatric patients. But there isn't that much pediatric cancer around, much less than there is prostate cancer. And that's the problem. If you've invested $150 million for a proton facility, you can't really pay for it entirely on pediatric cancers. Now, this has been very much in the news this week. I don't know if you've been following this on CNN or it's been in all the newspapers. This is the sad story of Ashaya King. Ashaya King is a 5-year-old child who was diagnosed 2 weeks ago at Southampton General Hospital in Britain with a medulloblastoma, a pediatric brain tumor. The tumor has been resected, but the child will recur unless he gets radiation therapy. We have proven, a number of centers have proven, that actually proton beam is the best treatment for this child. It's best because radiation, given any other way, runs the risk of a serious intellectual deterioration in the child and deafness. This child wasn't offered proton beam at Southampton General, but should have been, because we've treated a lot of patients from Britain, and the National Health Service will pay for them to be flown to Boston. This kid was not offered proton beam, and the father and mother literally kidnapped their child from a neurosurgical ward and left the country. Now, unfortunately, they did not do what... There's Southampton. Unfortunately, they didn't head to Boston. What they did is they fled to Spain, which is probably the worst place you can possibly go, because the Spanish economy is in ruins, and there will be no proton beam therapy now, soon, or probably forever. That's where they were discovered, and the parents were arrested, and the child was taken into care in Spain. They should have gone to Boston, or Florida, or Oklahoma, which also have contracts with the National Health Service. They're actually ending up going to Prague, where they can be treated there. So I do believe proton beam is a superb treatment for cancer. Pediatric cancer, eye tumors, CNS tumors, and spine tumors. But what about the prostate? It turns out it's not so obvious. It turns out that treating right into the center of an American man's body, that proton beam is no longer so razor sharp. It's fuzzy. We don't know where it stops. We have to overshoot. And so all the advantages that we have when treating a cancer of the eye or a cancer in a baby, because nowhere in a baby is far from the surface. But imagine if you're a big American guy. There's nothing further from the surface than the prostate. So a lot of the physical advantages are lost. Now, maybe advancing technology will smooth those out in the future, but they haven't yet. Now, in America, for many years, 15 years, there were just 2 centers, us in Boston, Loma Linda, close to here. A whole bunch more have been established recently, and these are all going in very shortly. The one thing you will notice is they tend to be going in pairs. That's because Hospital A gets proton beam, and then Hospital B down the road decides, God, we can't compete, we've got to get it as well. So there's an arms race going on. And the thing that distresses me is that most of these have a prostate cancer business model, not a pediatric cancer business model. And why is that? Well, what's called simple treatment, a prostate treatment, gives 70% of the reimbursement of a pediatric case. But you can treat 4 to 5 men with prostate cancer for every 1 child you can treat. So economically, prostate cancer has become the driver of the proton expansion. And because of this explosion of use of proton beam, and it has been, 75% of all patients treated in the US with protons have prostate cancer. The number of prostate cancer patients treated with protons annually has increased 5-fold in the last 5 years. So it clearly is a very important economic engine. And as a result, it's under great scrutiny. I spent the last 20 years scrutinizing this myself. Proton beam therapy is good treatment for prostate cancer. It's not sham treatment. It's not a joke treatment. It's real treatment. It's good treatment. It cures patients. But does it cure more patients, for example, if you have low-risk disease than brachytherapy? As far as we can tell, no. Does it cure more patients than other kinds of external beam? As far as we can tell, and I won't go into all the evidence, no. Well, maybe it doesn't cure more patients, but we could give higher doses with protons and cure more patients that way. Well, it turns out we're actually up to a ceiling in terms of radiation dose we can give. And when we tried to push it higher, as we did together with Loma Linda in a study, we couldn't take it any higher. We were limited by toxicity. All right, so we can't cure more patients, but surely at least we reduce the side effects. Well, again, I'm not going to go into the data in detail. There really isn't time for that. But every which way we've looked at it, we can't find that that is the case. The side effects from radiation are what they are. They're relatively low these days, other than impotence, which is relatively high. But the risk of serious rectal bleeding or serious bladder bleeding is really very low. And it's very difficult to prove that you can take a low risk and make it even lower. And then there's a new wild card that's been thrown into the mix recently. Thrown on the table, I suppose. That's too many metaphors. Wild card's been thrown onto the table. And that's the possibility that protons may actually increase the morbidity. Not reduce it, but increase the side effects. And the hint is that it might increase the number of rectal side effects. Well, how can this possibly be? Well, it may be because we don't understand the physics as well as we think, but it may also be that we don't understand the biology of proton beam cell and normal tissue cell kill. And there's a lot of work being invested to understand this better. So what's the evidence for a meaningful superiority of proton therapy in prostate cancer? Well, I've put all the evidence up there. But I hate spaces. So this is a nice picture of me and my wife in Barcelona. So I thought I'd fill the void somehow. So my fear is that at least as it is delivered today, in 2014, it is an improved means to an unimproved end. And there have been consequences to this use of protons. It's distorted the patterns of healthcare. It's paradoxically led to overtreatment of certainly men with low-risk disease. It's sucked resources from areas of medical need. So hospitals, instead of building a new surgery center or investing in primary care, are putting in a proton facility just to compete with the guys down the street. And they have no intention of ever treating pediatrics. And it's actually driven some hospitals to the edge of financial ruin. And seeing as we're very topical, this is this week's news. The Indiana University Proton Therapy Center is closing. And I suspect there will be others. This is going to, because many of the insurers are now saying, you know, we're not going to pay for prostate patients to receive proton beam therapy. So the business model then collapses. So we are yet to see how this is all going to shake out. So what are we doing? We've teamed together with UPenn, and we're doing a randomized trial comparing protons with regular radiation IMRT. We're well into that trial. We hope to have the answers. If there's an advantage to protons, we'll find it out. We'll find out how big it is, and then society has to decide whether it can afford it or not. If there's a disadvantage, we'll find that out too. And it's not just proton beam. New technologies are not tested the way that drugs are tested. The FDA bakes a randomized trial into its approval process. New technologies, we don't. And many of you have had robotic prostatectomies. And I'm sure many of you have done very, very well with a robotic prostatectomy. But this was a craze that swept the nation in the last decade. From 2006 to 2011, we went from 4% of American prostatectomies being robot-assisted to 85%. And have the outcomes improved? Well, it's questionable. And many guys who are doing a very good prostatectomy with their hands are now trying to use the robot, and they've dropped to the bottom of their learning curve again. So we'll see how that shakes out. But we need a more robust process for assessing new technologies. So I'm going to conclude by saying that market forces can overwhelm a weak evidence base. We've got lots of great evidence about broad issues, radiation and hormone therapy, dose of radiation, but not much evidence when it comes to technology A versus technology B. And when that evidence base is weak, patterns of care become disconnected from evidence. So I want to remind you guys to always remember the big picture. If you have intermediate or high-risk disease, radiation is very important, even if you start off with surgery, as is simple stuff, like the experience of the radiation oncologist. You wouldn't go to an inexperienced surgeon, as is the need for hormone therapy if you have high-risk disease, and as are all those little low-tech solutions, which are now part of our standard of practice. And as for the high-tech stuff, it's much less important than you think. And with that, I will stop. Thank you.